talk by Dr. Savleen, who's done a lot of work in this ROP babies and evaluating the refractive errors. I'll just touch upon things, what goes on their follow-up, what happens in the initial few years of their life during their childhood. So we know that prematurely born children are at great risk of refractive errors. That's quite evident. There's so many studies happening. And visual problems due to these are compounded by the presence of retinal pathology. So you have premature and even strabismus later in life. It's not just at the initial stage, but there exists variability in the occurrence and progression of such errors depending upon the stage and the management of ROP, which has been very well covered in the previous talks. So you can have just any kind of refractive error. Most common one is myopia. You can have astigmatism, you can have anisometropia, and yes, you can even have hypermetropia. All these tend to increase with increasing prematurity. So the lesser the gestational age, the more the chances. So if we come to myopia of prematurity, which is the most common one, any degree of myopia at 1 year would progress. So this was seen by a longitudinal study by Kaya et al., who followed their patients, although it was a retrospective, but it's a longitudinal study for about 6 to 7 years. And where they found that children with severe ROP had a higher myopia, and it did progress until 6 years of age, but then did flatten around 4 years of age. But yes, they had a severer myopia as compared to mild or no ROP. So in this study, they basically combined the mild or no ROP cases and saw that the myopia was less, but did increase till about 6 years of age, the severity of which was less than as compared to severe ROP. So prematurity and ROP are independent risk factors for myopia. This is a wonderful, again, a study which is done by Vijay Lakshmi et al. They've shown something, almost 5 years, where they found that when there's no ROP, there's a low risk of myopia. When there's mild ROP, with no treatment, there's a moderate risk. You can see here the curve is flattening after about, say, 2 years. And if you have an ROP that was treated, or maybe a severe case, you have myopia, which is much severer. Yes, the mild ROP and the severe ROP tend to almost remain stable after about 3 years of age. So what they showed was that if there is no ROP, what to look for is myopia in premature. So this is all about a preterm baby. So if you have a preterm baby with no ROP, we look for myopia. The level of risk is low. The myopia level risk is low. You can examine the child at 2 years of age. If there is ROP, but no laser treatment needed, then of course we have to look for factors like astigmatism as well. There's a moderate risk of such things happening. Then you examine the patient earlier at about 1 year of age. But you have an ROP, a severe ROP, which has required treatment, then of course he's or she's at risk of high myopia. You have astigmatism, you have associated severe in these cases, anisometropia. So these kids have to be really followed up, seen early, and followed up much more frequently. So when you have to prescribe in children with these refractive errors, it's more or less on an individual case basis, where you have mild ROP versus you have severe ROP. What to prescribe? These are general guidelines which are followed all over the world for cases other than ROP. But in ROP, yes, what happens is you need to prescribe earlier, because you know that the child is going to have a high refractive error. The child refractive error would progress for the initial years of their life. So what's the role of atropine? There's so much controversy. Atropine has come up in a large way for preventing the progression of myopia. It's not stopping myopia, it's preventing the progression of myopia. So, there have been randomized trials and all this stuff, and they've shown really good results. But in myopia of ROP, we don't have any such study. There are ongoing studies because atropine really affects the axial myopia. And what we've seen in ROP is lenticular or a corneal, because of the corneal curvature, increased corneal curvature. So this group by Chia et al., who have done you can say a lot of work on axial myopia and the role of atropine. The mechanism of action, although is unknown, but yes, till date now, it acts only on axial myopia. So until we prove that the progression in myopia in ROP is axial, probably this drug doesn't have any role. So coming to the other thing is, you have cataracts in ROP. Now, cataracts also can affect the refractive errors. Like cataracts can either develop spontaneously or after treatment with laser or lens sparing vitrectomy, LSV, lens sparing vitrectomy. It's seen in regressed ROP as well. It can occur any time from 2 months to 13 months. This is shown in a study by Kekuna et al. The incidence after LSVs ranges from 5 to 19%. But of course, these are all small studies. There is no large study to show if myopic shift behaves differently after cataract surgery. So these are some of the images which are provided by me by Dr. Savleen. I mean, you can see here, I mean, this is how to show the progression of cataract in a child who has ROP. So in this child, I mean, one of the eye, no lens sparing vitrectomy was done, in the other eye it was done. So this is a child where no surgery was done. You can see here some opacification. This is the anterior segment OCT. And how it's progressed 1 month and then 2 months later. Now here it becomes significant when we cannot do a retinoscopy and we have to intervene. So these are some things which we have to see while we are observing when you have patients or children with ROP who could have these issues. You can have little vacuoles in the lens which may progress or may resolve. So these things have to be kept in mind. If there is a significant cataract, then it can be complicated because these are patients mainly who could be having severe ROP, and we know that there is pachyphakia in ROP, which means you have a thicker lens, more than 4 millimeter in the anterior posterior diameter. You have a microcornea as well, and you have angle closure because there is all anterior segment is so immature, and all these things happen in mainly seen in laser treated eyes. Now, IOL implantation here, you can remove the cataract, but IOL implantation would definitely depend upon the biometric profile. As I told you, it's a microcornea. So microcornea, you will usually not implant an IOL. And you also have to see other structural parameters of the eye. Now, cataract surgery is not sufficient to tell the parents about the visual prognosis. It would definitely depend upon the severity of the ROP. So I have some interesting cases here about what happens to these refractive errors as the child grows. We don't have a child with a very long follow-up. They are just probably in the first year or so. So you have here a child who 31 weeks, of course, low birth weight. The axial length was 15.4. So you can see a very short, very small eye, and he has a steep cornea as well. Now, right eye, they gave anti-VEGF in Jan 2020, but the left eye required anti-VEGF plus a laser. So what happens after about 6 months, the axial length, which was 15.4, does increase to 19.3 in the eye with the anti-VEGF. But in the eye where you have done the LIO as well, there is a much more increase, which is 20.11. So this is a very short follow-up, just 6 months. The keratometry, as would decrease with age, does so, reaches to about 45 to 46. The lens thickness is about 3.6 in the eye with anti-VEGF, and it's 3.9 in the eye where the laser was done. So in this eye where laser was done, lens thickness is more as compared to the other eye. And when we do a retinoscopy, in spite of these values which are coming, the right eye and the right eye is plano, where the left eye is -10. So this eye, which has been treated with laser, is -10. But if you see the difference in axial length, it's not that much. The keratometry difference is not that much. The lens thickness is okay, 0.3 millimeters more. So probably everything is just accounting for this -10. So it just can't be that maybe because of an increased lens thickness, it was -10. It can't be explained with these findings. So another case is we have these twin babies, again 30 weeks period of gestation, low birth weight babies. So baseline value, what happens in the first twin? The axial length is 15.5, which is fairly same in the other eye as well. You have a steep cornea, 54, and again it's 54 here. The lens thickness in the right eye is 3.09, in the left eye is more. In the other baby, it's 3.8 and 3.79. Now at this time, at refraction is hyperopic, wherein in this eye, it's -1.5 in both the eyes. Now, what is going on? You have an increased lens thickness. This is accounting for the myopia, whereas all the other parameters are just the same. Now, at 3 months of age, what happens is, in the first twin, both eyes are given anti-VEGF. So it's just 3 months. So the axial length increased by 15.5 to 16.4. The keratometry starts to decrease in the right eye, whereas in the left eye, there's a delay, but the lens thickness is less. Whereas in the left and right eye of the other twin, You have both eyes lasered. The axial length is fairly as compared to the anti-VEGF group, but the cornea is much steeper. The lens thickness is much more as compared to the other eye. But fine, just see here, the refraction is 0.5, it's hyperopic. Although this is just 3 months follow-up, but there are numerous factors which are working, which could account for the hyperopia. There is no definite answer why this child has a hyperopia of plus 0.5. We have another group of twins here. So what happened here was in the first twin, laser was done. In the second, 2 injections of anti-VEGF was given. And what happened, the 6 months follow-up is, in the one with laser, you have minus 7.5 myopia. In the left eye, is minus 5.5. So there is a difference of myopia as well. The axial length is much more in the laser group as compared to the anti-VEGF group. The lens thickness is almost double as compared to the anti-VEGF group. The keratometry is almost the same. Obviously, anterior chamber depth would be less because of the increase in lens thickness. So this is a short follow-up, but you can see the changes which are occurring in some of these patients. And so the last case is, again, a 30-weeker, low birth weight, AP-ROP. The axial length is 14.89. So at about 30 weeks, this is the average axial length. It's a steep cornea. The lens thickness is 3.5 and 3.76, and the refraction is -3. So you have a retinoscopy of -3 when the child presents, and later on what happens is, when the child has received anti-VEGF in both the eyes, and 6 months later what you see is the axial length does increase to 18.9. It's not that much of an increase. The keratometry is decreasing. The lens thickness is 3.4, 3.5. That's fairly good. And the refraction has increased to 6.5, minus 6.5. So from -3 here, it increases to 6.5. Now, what are the factors here? If you see here, the keratometry is decreased from 55, that's 55, to 47 and 45, that's decreased. So myopia should be less. The lens thickness 3.5, 3.7 is 3.5, 3.5. Okay, not that much of a difference. Now, what is the difference? The axial length. That's 14, and that goes to 18. So we are not yet sure because it's just a 6 months follow-up, but things other than lens thickness and a steep cornea could be working in these babies. So I'll just summarize what I've just said, that predicting individual refractive outcome is not precise at the moment. From these 4 cases, as I've told you, maybe we require a longer follow-up. Myopia is less with anti-VEGF versus laser over a short period of 3 years. There are various studies on this. There's a meta-analysis on this. There's not much information regarding astigmatism, but yes, in these babies, we do require a long-term follow-up to manage the myopia and the lenticular opacities, which might progress or might regress. Atropine, there is no role as yet, but may be useful for selected cases only if you can prove that the progression of myopia is because of an axial component. However, the relative weight of refractive components, the axial length, the corneal curvature, the lens thickness for myopia of ROP during their follow-up, mind you, during the follow-up, because you already proven that at presentation, it's mainly because of lenticular and steep cornea. But during follow-up, what components are working, as we need to target those components, still requires more research. Thank you so much. And I'd like to acknowledge Dr. Savleen, who's provided me these photographs and the cases.